Thank you so much, Madhu sir, for a very wonderful, kind words. I've not mastered the technique. I'm still I'm not just struggling with it, but I'm learning every other day. So uh, after listening to a very lucid talk by Soham, I'll be talking about some of the techniques which I follow and which I've learned over a period of time uh, to to improve the outcomes of Big Bubble Dal. I hope my slides are visible. I hope my slides are visible.
Yeah,
Yes,
yeah.
sir. Yes, sir.
Go ahead.
Yes, sir.
Okay. For me, I feel that there are 4 essentials for a successful outcome of DALC. These are ABCDs, and I'll be talking subsequently in my talk what are those ABCDs. So A is anesthesia, as very nicely mentioned by Soham, that for a DALC, you always want to do under general anesthesia. It's a bit prolonged surgery, and also the target here is to bare the Descemet's membrane. So I imagine a situation where you have bared the Descemet's membrane and patient starts moving its eye. It'll be nothing less than a nightmare. And also imagine if you perforate the DM, then it's an open sky procedure where also you want to do under general anesthesia. So until unless contraindicated, general anesthesia is preferable. Second is the attitude. So we have to really understand, not every case of stromal keratopathy, you need big bubble. So don't be rigid and self-egoistic. Many times you feel that, no, we can big bubble in this case also, that case also. That is not the case here. A good selection is a very essential trait of a successful surgeon. So that should be avoided in cases where you have a very thin corneas and you have a history of previous eye drops and you have a deep scar. But at the same time, attempt big bubble in every case before switching to manual technique. Again, maintain balance and calm. With balance, what I mean is do not over-pressurize the globe because you're trying to expose the DM here. So instead of using regular Castroviejo speculum, it's better to use Jaffe's here, and always keep an eye. Always make sure that the globe is on the softer side to avoid bulging of the DM. And aqueous formation intra-op will take care of the globe pressure. So always keep draining fluid from the side port, and don't worry about that eye may become very soft because aqueous formation will continue throughout the procedure. And maintain calm. And don't think that what if you don't get bubble? You can try again, give you multiple attempts. And remember, even the most experienced surgeon can achieve big bubble only in 60 to 80% of the time. So it's not something, if you're not able to get it, that it's something which you're missing a lot. And don't think, what if you perforate? Most of the time, you'll still be able to continue with the DALC. Very rarely you need to convert to PK. Very importantly, be consistent. So be consistent with your technique and with your instruments. I'll be focusing mainly on instrument in this talk. And this is the regular steps which we follow for big bubble DALC. So you do a partial trephination, and then you remove the superficial stroma, then inject big bubble. You can do a bubble test if you're not sure, and then make a brave slash, and then inject viscoelastic material, then remove the superficial stroma, and then put a graft, and then suture it. So pre-op planning, as mentioned by Soham, is very important to decide the size of the trephination and to decide the depth of the trephination. So you should plan to cover as much as ectatic area of the cornea. Usually the size varies from 8.25 to 8.5, and look at the thickness at the Pachy map, and look at the central Pachy and look at the peripheral Pachy both. And to decide the depth of the trephination, you basically want to remove 30 to 60% of the anterior stroma, and the target would be to leave at least 150-200 microns. So suppose this cornea has almost like 375 microns in the center. You want to remove around 200. So you put your depth at 200, and then you'll be left with 175 after once you dissect. So this is a case of post-DALC inferior ectasia where actually some of the keratoconus probably was left while trephining and was not removed, and later after 3 years it presented with a closed junction ectasia. In spite of all the things which can go wrong, which you don't expect, and this is the Hana's Moria trephining system, and this is so you are putting on the cornea. Always do not take the full vacuum, take only half vacuum, and then start and then there you go. You see the perforation. Now, so probably the cornea was thick here or was not planned properly, and then as this case will convert to PK. So right tools and instruments are the most important part of achieving a good big bubble. I would say TAN's marginal dissector is one of the most important tool for achieving a big bubble, and at the same time the big bubble cannula. And these are the other scissors. Sean mentioned scissors. Amber scissors are very good, and the blade markers from Thomson is again a very good addition to your instruments set. Again, marking the center is a very important aspect. So marking the center of a bigger circle is it's not that accurate. So basically what you're trying to do here is trying to create a smaller circle and then mark the center of that smaller circle. So I've created 4 points and then marking the center in the middle of that 4 points. Okay. Another important aspect would be to always keep the surface dry before marking so that you don't have that smudge there. And then there's a marker where you actually meet the two, where you actually mark the center with the pointer here. This is helpful in future marking. Then coming after you have done the trephine, then the stromal dissection. So there are 2 ways of doing stromal dissection. Sean very nicely pointed out. I would just add a little bit here. So if you want to remain in the same plane, do a closed flap dissection. And if you think that you have gone deeper, then you'll have to do an open flap dissection. Like here, I'm doing an open flap because I think I've gone too deep and I'm scared that I may perforate. Then again, I feel that, okay, now the plane is good. I'm maintaining the same plane with a closed flap dissection. So there's a mix of both, and there's a small mini scissors where you cut at the graft-host junction. Then again, a superficial dissection here with the open flap. So the tip would be, if you want to maintain the same plane, do a closed flap. And if you want to do a superficial, do an open flap dissection. Then it's time to inject the bubble. Once you have done the trephine and you have seen that, okay, there is a good depth stromal tissue, then you can create the track either with the marginal dissector or use a 27 gauge needle. The important thing here would be to, again, with the cannula, you have to go beyond the track of beyond the track which you have created. So I've already created a track here, and then now I'm going with the cannula beyond the track, so that you have a closed chamber there, and with the pressure of the air, the DM separates. Like here, there you go. You have the big bubble, and then slowly take out the cannula. Once you have the bubble, make a paracentesis and decompress the anterior chamber. So when we get a big bubble, you think you have achieved everything, but it's not the case. Like here, I was struggling. So I've got a big bubble, but I'm not able to take the cannula out. So because it has become a very high pressure chamber, and I was trying to take the cannula out, but somehow I could not. So what I did was finally, this is the wrong technique. So you have to actually hold at the graft-host junction here at the edge of the, and then it comes out. Again, paracentesis to decompress. Again, don't go too much inside because you may burst the bubble. So just be on the periphery and then take it out. So the paracentesis should be vertical to avoid inadvertent rupture of the Descemet's membrane. Once you have got the big bubble, now it's a defining moment, the moment for brave slash. And you put a dispersive viscoelastic here so that you basically want to prevent this sudden bounce back of the Descemet's once you get rid of that bubble. So now I'm trying to attempt that slash. I'm not that brave. So small, gentle movements, repeated movements, and there you go. So you have the bubble just escaped, and then again decompress the chamber. So always keep decompressing the chamber at every steps. Now I'm trying to separate that Descemet's membrane with the posterior lamella, and this is the marginal dissector. So this marginal dissector has two side projections, which actually helps a lot in removing those fibers. And it has a the posterior surface is very flat, so there's negligible risk of mismatch. Obviously, you can go poke it, but then you'll have, but most likely you'll not have that. Another very important tip here is when you're dissecting, try to go beyond the margin of that graft-close junction, so that if you go beyond and dissect it, you'll have that edge to hold when doing the sutures. So donor graft preparation, it's very simple. Shom has already talked about. Sizing the donor is again very important. If there's a too much of myopia which you want to compensate, then probably you'll have to undersize by 2.25 mm. But if there's not much myopia, probably you can take the same size. And I remove generally both endothelium and epithelium. Epithelium just to avoid the risk of epithelial rejection. And we often use therapeutic grade tissues for our DALK cases. So again, a very important tip here would be, since these therapeutic tissues are very thick and bulky, so it becomes difficult to suture. So always keep them dry for 10 minutes before you use them. So then in that case, it becomes dehydrated and the cornea actually becomes very less bulky, and then it'll be easily sutured. Again, you have the option of suturing with interrupted sutures or continuous sutures. Suture bite in the donor should be around 50 to 60% depth, and in the host around 90%, because it helps in better opposition of Descemet's membrane with the donor. You can see the diagram here. And always use a very sharp tip needle to avoid hesitation at the graft-close junction. Many times this is the cause, those blunt needles are the cause of the perforation. Now, coming to suturing. So even before you start suturing, make sure that the surface, the area is dry. Here I'm trying to decompress and then I'm drying it. The reason why I'm drying it, keeping it dry, because anytime if you are having that perforation, aqueous will leak, and then if it is dry, you'll be able to note it. But if it is wet, then you'll not be able to note. Again, the very important tip for this while suturing these DALK cases, because most of the time perforation happen in these steps. So what you do is, don't come out of, once you have taken the bite, don't come out at once. So like here, you'll see, I'm going with the suture needle, holding it, and then, yeah, so you have gone, you have taken a bite there, and then 1, 2, and 3. So don't come out at once, because the back end of the tip may perforate the Descemet's membrane. And always keep it dry. So the final touch, Shom has already showed, use an intra-op keratometer. And just one point, before you use an intra-op keratometer, always keep the surface wet, because the Myers will be able to see the reflections of the Myers much better. And if you're satisfied with the Myers, you can go ahead, or you can put additional sutures or loosen those sutures. Okay. And, so once you have sutures, you can put a bandage contact lenses. Again, the D is for Descemet's membrane. It's not essential to bear Descemet's membrane all the time. Sometimes you'll not be able to do. And so definitely visual acuity is superior.
With due all respect, Dr. Ashish, can you please sum it up in the next 1 minute?
It's okay. Let him continue.
Okay, fine. Yeah.
Visual acuity is superior in case of big bubble DALK, but again, it's comparable to manual technique. Definitely, visual recovery is much faster with big bubble. Manual technique also has very good results. If you are close, if the dissection is around 80 microns of Descemet's membrane, the results are pretty good. Some of the newer developments like femto-assisted DALK and intra-OCT to guide the depth of the air injection, these are very expensive tools, and it's not very reached optimum. I would say the experience is still very lacking, and the clear-cut evidence is not there, and also very expensive. So in summary, I would say big bubble in DALK can often be achieved if you have the right case, and if you have a proper training and and the technique, and most importantly, if you have the right instruments with a positive attitude. Thank you so much.